Dr. Chaitanya Buva to come to the podium, and he came all across from Nashik, and he is a consultant endocrinologist in a hormone care. Nashik has vast experience of 17 years, public lots of research papers on that, and he's speaking on evaluation of Cushing syndrome and Cushing disease. Over to Dr. Chaitanya Buva.
Yes, thank you, Pankaj. Good morning, everybody, and I think I am the opening batsman, and in the opening session of endocrine. At the outset, I want to thank Team APR Con to give me this opportunity to be a part of this grand event. And I feel really honored to share the stage with my teachers, Nalini Shah Madam, Chadda sir. This is just reminding me one chronology. So in 1912, way back, Harvey Cushing, he described the case of obesity, hirsutism, and amenorrhea. And 20 years later, he postulated that this is a polyglandular syndrome, and because of the multiple gland dysfunctions, this problem is occurring. And thereafter, many studies were done on this syndrome, and it came up with some adrenal masses also can lead to this type of syndrome. Then ectopic ACTH production can lead to pituitary mass can lead to this type of syndrome, and so many things they came into picture. Thereafter, I learned this Cushing syndrome from Amrita Institute of Medical Sciences, Kochi, and then I really feel very fortunate to be a student of Nalini Shah Madam, and I learned a lot of things from Cushing's disease, Cushing syndrome at KEM. And recently, I have come across one patient of adrenal Cushing syndrome who came to me for follow-up after 4 months of adrenalectomy for the adrenal mass, and she was very happy with the recovery that happened, and she conveyed just thanks to me, and I'm just reciprocating and conveying this thanks to all my teachers who have guided me throughout all these things. So today in this talk or in this discussion, we are going to have in short discussion about the evaluation or workup of Cushing syndrome. So let us start with that. So I'm just putting one example of the case. She is now 38 years lady, obesity, hypertension, pre-diabetes, oligomenorrhea, facial hairs, acne. This was the presentation. On examination, there was central fat deposition. There was double chin, round face, buffalo hump, striae, and she was outside worked up with 8 AM cortisol, which was 16 microgram per deciliter, and 4 PM cortisol was 10 microgram per deciliter. CT adrenal was done, that was normal, and MRI pituitary showed 6 millimeter microadenoma. And then this case was referred to me for evaluation or workup for Cushing syndrome, suspected Cushing syndrome. So now my first question is, what is the differential diagnosis? Is it really a Cushing syndrome? What do we feel? Is it sufficient to say this as a Cushing syndrome, or something else is required? So is this Cushing syndrome? That is first question. Is it PCOS? Is there any other possibility? So many questions will arise at the onset itself. So is it a Cushing syndrome? If yes, is it a Cushing's disease? And or else, if there is something else possible, what is possible and why it is possible? So these are all the questions when they come to our mind when we see the case like this. So what is Cushing syndrome and what is Cushing's disease? So Cushing syndrome, it is nothing but it is the syndrome or signs and symptoms arising out of chronic exposure to high levels of glucocorticoids in an inappropriate way. So the glucocorticoid imbalance will be there, and that leads to a sign and symptom constellation which leads to Cushing syndrome. And it has got a variety of causes. Cushing's disease is the Cushing syndrome because of the pituitary origin. So pituitary mass which will lead to increase in ACTH levels, and ACTH dependent Cushing's because of the because of the ACTH hypersecretion from the pituitary. That is nothing but the Cushing's disease. And this is the most common cause, after exogenous Cushing's, it is the most common cause of Cushing syndrome, we can say. So these are the clinical presentations. So here we can see typical obesity, central obesity, mooning of the face, facial plethora, hirsutism, then a boy with short stature, gynecomastia, round face, then ecchymosis, bruising of the skin, and these are the striae. So these are the different clinical signs which lead to a suspicion of Cushing syndrome when we face these type of cases. So what are the causes of Cushing syndrome then? We'll just discuss about what are the possible causes and then how to evaluate and how to go ahead with the workup and evaluation. So we can summarize that ACTH dependent causes, ACTH independent causes, and other causes of hypercorticolism which are non-neoplastic, we can say physiological or pseudo-Cushing's. So all these things we need to consider when we are seeing the cases like this, so that errors will not be there in diagnosis and ultimately in the treatment. So ACTH dependent causes, it's a Cushing's disease which is the most common cause, pituitary dependent, then ectopic ACTH, ectopic CRH syndrome. So non-pituitary organs, masses, especially the neuroendocrine tumors, they will lead to ACTH secretion and CRH and will lead to Cushing syndrome. Then macronodular adrenal hyperplasia, iatrogenic treatment with ACTH, all these things are these are rare causes. So ACTH dependent causes, ACTH independent causes, adrenal adenoma and carcinoma, primary PPNAD, then macunal rite, again these are rare causes we can say, aberrant receptor expression, gastric inhibitory peptide and interleukins in the adrenal glands, and iatrogenic causes of ACTH independent syndrome, which is the most common cause of Cushing syndrome, and that we come across during our clinical practice in a very common way. So iatrogenic steroid treatment or factitiously steroid treatments are given to the patient, and that can present with Cushing syndrome, and these are iatrogenic or exogenous Cushing syndrome, we can say, ACTH independent cause. And other causes of hypercorticolism, non-neoplastic, this we must exclude because otherwise it will lead to a misdiagnosis. And these are non-neoplastic physiological causes, pseudo-Cushing we can say. So chronic alcoholism, especially with the alcohol withdrawal, then depression, stresses, obesity, pregnancy, and so many other things can present with pseudo-Cushing presentation that we need to identify from true endogenous Cushing's or true Cushing syndrome itself. So pseudo-Cushing, then Cushing syndrome. In the Cushing syndrome itself, we have to differentiate between ACTH dependent and ACTH independent, and then it will guide us towards the appropriate treatment lines for the patient. Now, the most common cause we have seen, it is iatrogenic Cushing. Second is Cushing's disease, so pituitary cause. And in the ectopic ACTH syndromes, these are the different causes. So small cell lung carcinoma in 50% of the cases, that is the cause. Then comes neuroendocrine lung tumors, pancreatic neuroendocrine tumors, thymic neuroendocrine tumors, and then non-small cell lung carcinomas and many other things. For example, medullary carcinoma of the thyroid, then pheochromocytomas and other rare carcinomas which may present with ectopic ACTH syndromes. And these are very important to know because the treatment will depend on what is the cause for Cushing's. So in our diagnostic approach, the first thing is we have to be sure about what are the discriminatory clinical signs of Cushing syndrome and what is the level of suspicion. And depending on that, we have to carry on with screening tests, confirmatory tests, differential diagnosis tests, and so many other things. But first thing is level of suspicion, and that will depend on your first clinical evaluation. Then exclusion of exogenous Cushing through the proper history tracking, steroid medicine history, and so many aspects of exogenous Cushing, we have to go into the clinical details. Exclusion of pseudo-Cushing. So that background of pseudo-Cushing, so any psychiatric disorder, anxiety, stresses, depression, alcoholism, severe obesity itself, and so many other things, we have to go clinically through that and exclude the pseudo-Cushings. There are tests, but no Cushing workup test is 100% sensitive or 100% specific. So we have to be careful about it. It is a very complex disorder. Even for endocrinologists, it is a very complex disorder. And all Cushing's cases, we learn from each case. Something new we learn from that. So test to know whether it is Cushing syndrome or not. That is the next step. So these are the screening tests. And test to know cause of Cushing syndrome. So differential diagnosis, Cushing's disease or something else. So this way we have to proceed with our Cushing's evaluation. So what are the discriminatory signs which are specific for Cushing syndrome itself? Facial plethora, proximal myopathy, cutaneous striae, which are, so these are the catabolic signs. So red-purple striae, more than 1 centimeter, so wide red-purple striae, bruising, easy bruisability. And in children, the most specific thing, all these things can be absent in children. So most specific thing will be weight gain and reduced height percentile. So these are the things, and we have to have a very low level of suspicion for the diagnosis in these cases. So other less discriminatory signs and symptoms are there. So these are non-specific. They share the common features with many other hormonal and as well as non-hormonal problems as well. So after this, test used in the diagnosis and differential diagnosis of Cushing syndrome, diagnostic test, does the patient have Cushing syndrome or not? That is the first step. So in this, some screening tests we can, screening and confirmatory testings we can do. And I will just highlight 3 tests: late night salivary cortisol or circadian rhythm of plasma cortisol. So midnight cortisol. That is one, urinary free cortisol excretion, and low dose dexamethasone suppression test. These are the 3 tests which we use in screening and confirmation of Cushing syndrome itself. And in the differential diagnosis, what is the cause for that Cushing syndrome, why it is happening? In that, first step is plasma ACTH. So ACTH level, we have to be careful about this ACTH level and its temperature maintenance, because many times pre-analytical errors can lead to misdiagnosis because of the altered ACTH level. So we have to be careful how to collect this ACTH sample, how to maintain the temperature, how to freeze the samples before analysis, because many of the times this ACTH test is not commonly available in common labs. So plasma potassium, bicarbonate levels, then high dose dexamethasone suppression test, then CRS stimulation testing, inferior petrosal venous sampling, CT, MRI, scanning of the pituitary and CT of the adrenals, then nuclear studies and tumor markers. So this all will come through that process, and ultimately with these type of setting of tests or combination of tests, we can reach to a proper diagnosis of Cushing syndrome and what is the etiology for the Cushing syndrome. So we'll just discuss in short about all these tests. 8 times serum cortisol, that is the first test to be done. So diagnosis of exogenous Cushing's, so features suggestive of Cushing's with low or suppressed serum cortisol. That gives us a clue about exogenous or iatrogenic Cushing. Even cyclical Cushing sometimes can present like this. So intermittent secretion of cortisol, cyclical Cushing or intermittent Cushing. So we have to be careful about this aspect of Cushing syndrome in these cases with 8 AM cortisol. Cortisol assay can be affected by OC pills, pregnancies. So we have to know this aspect of this test. Then midnight serum cortisol or salivary cortisol. Now what are the plus and minus for both the tests? Midnight serum cortisol, it is a sensitive tool, so it is a very sensitive test we can say, but it is really cumbersome, and many times it ideally requires admission, and false positives need considerations because of the stresses and so many other things. Then it is affected by OC pills and pregnancy, pre-cannulation, heparin lock, all these things can be required to elevate the effects of venipuncture stress as well. And so these are the different caveats for this test, and more than 7.5 microgram per deciliter is suggestive of Cushing syndrome, less than 1.8 rules out Cushing syndrome. So this is the one test. And similarly, now we have got this salivary cortisol. So midnight salivary cortisol or late night salivary cortisol. So at bedtime, we can collect the saliva samples either by passive drooling or chewing method. So it is easy, convenient, we can repeat it easily, it can be done on OPD basis. on outpatient basis, useful in cyclical Cushings because multiple readings we can do, and this salivary cortisol assay is very stable at the room temperature for longer time. So the patient can come up with repeated samples as well. It is useful in cyclical Cushing because of this feature. It is not affected by cortical binding globulin levels and medicines. Assay availability or the experience is the main problem here, and that's why it is not in common use. Age, hypertension, and diabetes can lead to false positive results. And more than 2 nanogram per ml cutoff, so it depends on the assay. So ELISA or LSC, which assay we are using, depending on that, the assay cutoff can depend. But in general, this cutoff we can use it for that, and it is having 100% sensitivity and 96% specificity. So this is again a sensitive test, but because of the assay availability and experience, this is not in common use. Now 24 hours urinary free cortisol. This is another test. So it is free of CBG related issues. It is less sensitive. So adequate sample collection is required. Multiple collections can be needed. And milder cases or cyclical cases we can miss because of this assay. So milder cases, because of the less sensitivity, we can miss these cases with this 24 hours urinary free cortisol. Adequacy of 24 hour sample must be considered. Even hydration and a lot of polyuria or increased fluid intake by the patient can have some false positive results. And usually 3 times the upper limit of the normal range is needed for the unequivocal conclusion. So it again depends on the assay, and the assay upper limit 3 times that it is a significant. Otherwise we cannot rely on that, only on that basis. Then low dose dexamethasone suppression test. Here there are 2 types of tests. So overnight dexamethasone suppression with 1 milligram of dexamethasone and cortisol level next day. This is one screening test. And 2 days, 0.5 mg dexamethasone 6 hourly for 2 days and then cortisol. That is standard LDDS test. So the cutoffs 1.8 cutoff. So less than that it rules out Cushing's. So this cutoff is having a very good sensitivity, almost 100% true positivity and less than 1% false positivity with 2 days LDDS. CBG levels, OC pills, pregnancy, it can affect the levels. Again, rifampicin, phenytoin, and many other medications which can alter the dexamethasone metabolism itself. It can lead to errors in the levels of cortisol because of the dexamethasone metabolism abnormalities may require serum dexamethasone levels. So when we are doing it, ideally we should retain the sample for the dexamethasone levels if it is required, if there are not adequate results. So we have now gone through different tests which can be used for Cushing syndrome and Cushing's differential diagnosis. Now first we will go through how we should proceed in the evaluation of Cushing. So suspected case of Cushing syndrome, what we should do first is exclude exogenous glucocorticoid exposure. So do one 8 AM serum cortisol, see the clinical picture, that will guide us to exclude the exogenous glucocorticoid exposure. Then comes these 3 tests. So 24 hours urine free cortisol, overnight dexamethasone suppression test, and late night salivary cortisol. So salivary cortisol 2 tests and minimum 2 tests of UFC. These are required. Consider caveats for each cases. We have to individualize the test for the individual case. Use 48 hour and 2 milligram DST in certain populations. Dexamethasone suppression with 2 mg. If these tests are having normal test, Cushing syndrome is unlikely. Now it again depends on level of suspicion. If it is a high index of suspicion, we have to further see whether it is really negative or not. And we have to repeat the test, different test combinations we have to use. If it is a low index of suspicion and one single test negative, that also can tell us that there is Cushing syndrome is unlikely in these cases. Any abnormal result? Exclude physiological causes of hypercorticolism. So clinical clues we have to get, and we have to do the multiple testings for this, and we have to even treat the initial cause if we are suspecting any sort of pseudo-Cushing. So alcoholism and withdrawal from the alcohol. So all these things we need to treat them and then repeat the testing so that those will give us the clues. Severe illness, obesity with the weight loss we can try. Uncontrolled sugars, we have to control the blood sugar levels. and blood glucose levels and then repeat the test. So repeat testings can be required for this. And there is one test called as LDDS CRH testing, CRH stimulation, CRH if it is available. This can definitely differentiate this in some difficult cases. So CRH will stimulate the cortisol level after dexamethasone suppression test if it is a Cushing's disease. If it is a normal or if it is a pseudo-Cushing's, it will not lead to increase in cortisol levels after dexamethasone suppression. So CRH stimulation after LDDS, it can be one of the tests which we can use at this setup. Perform 1 to 2 other studies shown above. Repeating the abnormal study is suggested. So if one test is abnormal, we can repeat it for the consistent results, and 1 or 2 studies different we have to do. And if the 2 tests are concordant for the Cushing syndrome, then it gives us the clue that it is a Cushing syndrome. Repeating the abnormal tests it suggested, dexamethasone CRH or midnight serum cortisol, because it is the most sensitive test, circadian rhythm assessment. So that can be used in mild cases or cyclical Cushing's, milder cases of Cushing syndrome we can use it, especially if above tests are equivocal or discordant, above 3 tests, then dexamethasone CRH and midnight serum cortisol can be used in this setting. Now if it is normal, then Cushing syndrome is unlikely. If it is abnormal, so 2 tests are positive, high index of suspicion for Cushing's, Cushing syndrome is likely. Now we have to go towards what is the cause for Cushing syndrome itself. So Cushing syndrome clinically or biochemically confirmed, and just remember that this biochemical screening and confirmation is very basically important for any evaluation of Cushing syndrome, because directly imaging can lead to many errors. Now we have one case of Cushing syndrome, a lady presented with Cushing syndrome who had almost 3 tumors, one in the adrenal gland, one in the pituitary gland, and one in the bronchial chest mass, so bronchial mass. And now what is the cause for that, how to treat? These are all things which are dependent on the initial biochemical screening. We should not jump to the imaging modalities directly. Differential diagnosis, here ACTH level, as I told you, if it is suppressed, less than 5, more than 10, these are the cutoffs, less than 5 suppressed, then we have to image CT adrenals, consider macronodular hyperplasia in these cases, so we have to consider that. And adrenal mass, if it is unequivocally present, then it is, we have to treat it accordingly, we have to treat with adrenal mass surgery. If ACTH is detectable, now 5 to 10, more than 10 if it is there, then it is ACTH dependent. 5 to 10, we have to do again CRH testing. That can confirm whether ACTH is getting stimulated. ACTH dependent disease, how to go ahead? 50% cortisol suppression following high dose dexamethasone suppression. So HDDST cortisol suppression, that is one. Then 50% increase in serum cortisol post CRH stimulation, that is second. So this plus this, 2 findings, and plus positive MRI scan of the pituitary. So more than 6 millimeter adenoma, if it is a macroadenoma clearly, then it is Cushing's disease. If all the things are concordant, if these criteria are conclusive, Cushing's disease is likely, we have to go ahead with the pituitary aspects treatment. If these are inconclusive or equivocal, failure of the above criteria, any of that, then we may have to go ahead with inferior petrosal venous sampling with CRH stimulation. If there is a positive ACTH gradient more than 3, then it is a Cushing's disease, treat it accordingly. If it is less than 3, then we have to go ahead with workup for ectopic ACTH syndrome. So no ACTH gradient, ectopic ACTH syndrome, so appropriate radiology, CT, MRI, so MRI pituitary, CT neck, chest and abdomen pelvis, nuclear studies with DOTA-NET scanning. So all these things will be required, especially in the cases where the Cushing's diagnosis is not certain, and this happens many times, so we have to be careful about it. So back to our case, when we saw that case, I think we should not say Cushing syndrome at that point of time. We have to go ahead with many of the screening and confirmatory tests and then say that it is a Cushing syndrome.
Last minute, please.
Yeah. So clinically focus on discriminatory signs of Cushing syndrome for deciding level of suspicion, rule out iatrogenic possibilities, exclude pseudo-Cushing, Stepwise adequate biochemical evaluation is required before going to imaging. Don't jump to imaging directly, can lead to serious errors. I think that's what I just want to say about Cushing syndrome evaluation, and I'm really thankful for your patient listening. Thank you.
Thank you, Dr. Chaitanya.